Welcome. Today's topic is going to be acute pulmonary embolism, which is one of the most important medical emergencies. So by definition, an acute pulmonary embolism refers to an acute condition that results from clogging of a clot into the pulmonary arterial circulation, and this results in reduction of the blood flowing to the pulmonary arteries. In other words, it compromises pulmonary circulation. This is a very important medical emergency that requires immediate attention. So we want to look at the classification of pulmonary embolism. It's basically classified into three main types. There is a small or moderate type. This one is associated with normal hemodynamic parameters. There is also normal right ventricular function and size. Then the second one will have what we call the submersive. Here the patient is still hemodynamically stable, although with moderate or severe right ventricular dysfunction. They may also be coupled with an enlargement. Then we have a massive type. This one is associated with a number of hemodynamic disturbances, that the likes of hypotension, there are features of poor tissue perfusion, there may be multisystemic organ failure, there may be right or left main pulmonary arterial thrombus. So what are the risk factors for one to get an acute pulmonary embolism? Of importance, there is positive familial history. Then you can have obesity, recent surgeries, especially orthopedic surgeries. There is trauma, there is immobility and acute infections. You may have thrombophilia as another important risk factor. You can have malignancies, we can have pregnancy, cigarette smoking, can have also advanced age. But of importance, I want us to clarify about thrombophilia as one of the main risk factors of an acute pulmonary embolism. The thrombophilia may come as due to hereditary causes, may also have acquired causes. So some of the disease conditions which are hereditary and can result in thrombophilia include protein C deficiency, you can also have protein S deficiency, you can have antithrombin 3 deficiency, you have factor V Leiden deficiency. The acquired ones, the common one is antiphospholipid syndrome. You also have hyperhomocysteinemias. So what are the signs and symptoms of an individual who is having an acute pulmonary embolism? So a patient having an acute pulmonary embolism may have an acute onset of dyspnea, there may be priority chest pain, there may be a cough. In most cases it is non-productive cough, there may be hemoptysis. When you examine, the patient is cyanosed, there are features of hypoxia, the patient may be tachypneic, may be tachycardia. These are compensatory mechanisms. The patient may be hypotensive, there may be low-grade fevers. They may have signs of deep venous thrombosis, and this can be a point of focus from which a pulmonary embolism might have culminated from. Patients with severe cases may present with syncope attacks. There may be hypotension. We may have cardiac arrest. There may be other evident features of pulmonary hypertension. These include audible P2. There may be a murmur of tricuspid regurgitation, although this may happen in chronic cases. So what are the complications of pulmonary embolism? Complications can be disease-related or treatment-related. The disease-related complications will have cardiac arrhythmias, you can have pulmonary hypertension, there may be copulmonal, there may be right-sided heart failure, you may get a cardiac arrest. Treatment-related is basically hemorrhage as a side effect of most of the anticoagulants, the likes of warfarin and heparin. So the investigations for patient who is having a pulmonary embolism: one, we'll have a chest x-ray. Even in lower settings, a chest x-ray can help us diagnose features of a PE. And the evident features here, on an x-ray you may see features of atelectasis or parenchyma abnormalities. The hemidiaphragm may be elevated, you may see a pleural effusion. There is what we call a Felsoni sign. In this case, a pleural effusion may be dominant on the left side or the left lung field as compared to the right. Is what we call a Hampton's hump. This Hampton's hump is a peripheral pleural-based wedge-shaped density that is seen above the diaphragm due to a pulmonary infarct. We may as well have what we call a Westmark sign. A Westmark sign simply refers to a distension of a pulmonary vasculature, which is oftentimes proximal to the embolism, and it comes along with loss of vascular markings distally. In other words, it is a localized peripheral oligemia. Then you can have a Pala sign, which is an enlarged right descending pulmonary artery. You can have Fleischman's line, which are long curvilinear densities which are reaching the pleural surface. You can as well have the Fleischman's sign, which simply refers to a dilated pulmonary artery. So these are all features you can look at on a chest X-ray to give a diagnosis of a pulmonary embolism. You can do Ecg changes. There are quite a number of Ecg changes that happen. It can be a sinus tachycardia, which is seen in more than 44% of the patients. You can see an incomplete or complete right bundle branch blockage in 18% of the patients. You may see right ventricular strain pattern, maybe seen around 34% of the patients. You may have a right axis deviation. You can as well have a T-wave inversion and so many other changes. Although non-specific, but they can help us single out diagnosis of pulmonary embolism. Other investigations include arterial blood gases. You can do cardiac enzymes, you can do echo. You can as well do a duplex Doppler ultrasound scan of the lower limbs, especially if there is a high index of suspicion of a DVT as the focal point. You can do D-dimers, although non-specific. A chest CT can as well be important. You can do a ventilation perfusion scanning. But the gold standard for one to diagnose a pulmonary embolism, here we have to do pulmonary angiography. So having diagnosed pulmonary embolism, how do we go ahead to manage a patient who is having the condition? So the general principles of management: 1, keep the oxygen saturation above 90, and this is done by supplying oxygen. If the patient is desaturating, then you keep on oxygen. You can have, for a patient who is hypotensive, you do IV fluid resuscitation. And of course, for hypotensive patients, try as much as possible to avoid diuretics, as they could worsen hypotension. So stabilize the patient and treat according to the classification of the pulmonary embolism, which we talked on earlier on. So in this case, the specific management will be in such a way that a small to moderate pulmonary embolism, you simply manage it with anticoagulation. The submassive type, you do both anticoagulation and thrombolysis. Then the massive type, you do thrombolysis using agents such as streptokinase. You can use altiplase, you can use recombinant TPA. After that, then you follow it up with anticoagulation. So at this moment, I want us to talk about anticoagulation. It's one of the gold standard ways of managing pulmonary embolism. We usually manage with low molecular weight heparin, such as enoxaparin, which is given as 60 milligrams BID, or you can give it at 1 milligram per kilogram, and preferably given subcutaneously. If you don't have low molecular weight heparin, you can use unfractionated heparin, which you can give at 10,000 international units IV bolus, followed by an infusion of 1,000 international units per hour. And for this case, you aim at an activity partial thromboplastin time of the patient being twice the control, and it is done, of course, when the low molecular weight heparin is not available. So once you've used the heparin, again you maintain the patient on warfarin, what we call warfarinization, 5 milligrams once daily. Although warfarin requires routine monitoring of international normalized ratio, and this INR must be kept within 2 to 3. You can as well opt for other anticoagulants such as rivaroxaban or sinotron. So we want to talk about the duration of therapy. Now, DVTs which are below 3 months, DVTs which are below the knee are supposed to be managed for 3 months. Then those above knee are supposed to be managed for 6 months. If someone has a pulmonary embolism, you have to manage for 1 year. A patient who has been having recurrent DVTs, here we mean 3 times of DVT and more, you have to anticoagulant for life, what we call an indefinite anticoagulation. It is advised that you start heparin and warfarin at the same time. Preferably you start heparin today, and then in the evening of the same day, you start warfarin. But you stop the heparin once the INR reaches 2. So you have to monitor the INR on daily basis until it reaches 2.5. Then of course, you keep monitoring weekly. You can also shift to monthly if the patient is stable. However, if the patient is unstable, you have to restart closer monitoring of international normalized ratio. Let us talk about fibrinolytics, which is another important tool of managing especially the submassive and the massive types of pulmonary embolism. This one is oftentimes indicated in the patients who are hemodynamically unstable. That's why we reserve it for the submassive and the massive type. Commonly, we use streptokinase, which is given as 250,000 international units given IV for over 30 minutes, and this is followed by 100,000 international units, that is per hour, for 24 hours. Now, despite the fact you can have anticoagulation and fibrinolysis at the same time, there may be some cases where the two are contraindicated. And these can be the absolute contraindications and relative ones. Relative, we mean you can do some reservation. You weigh the risk versus the benefit. So the absolute, any prior intracranial hemorrhage, such as cerebrovascular lesion, if there is a known intracranial neoplasm or any other space-occupying lesion, if the patient has had an ischemic stroke within 3 months, if the patient has a suspected aortic dissection, or the patient actively bleeds, or the patient has other underlying bleeding diathesis apart from menstruation, history of head or facial trauma within the last 3 months, these are absolute contraindications to anticoagulation. Then the relative ones, where you could weigh the risk versus the benefit. If a patient is having active peptic ulcers, current use of anticoagulants or the prior use of anticoagulants, if a patient has severe uncontrolled hypertension on presentation, the patient is pregnant, or the patient has a recent history of internal bleeding within 2 to 4 weeks, then these are relative. We could weigh the risk versus the benefit. Now, in scenarios where thrombolysis and anticoagulation are a bit contraindicated, then we offer surgical measures. In particular, we do embolectomy. Then the supportive care, you can do compression stockings for patients who have proven cases of deep venous thrombosis. So the major recommendations, as we're summarizing, for a patient who may manage for pulmonary embolism, refer a patient to tertiary institution if one, they are having a massive PE that is not responding, or if it is a complicated PE. If that patient has inability to initiate or monitor anticoagulation, or if there is need for ventilation or surgery, these are cases where you're supposed to refer the patient. I thank you for watching us. Keep subscribing to our YouTube channel for this and more of the videos to come. Thank you very much. I remain Dr. Mbiro Michael.